Hi everyone, Sanil Rege, consultant psychiatrist. Today I'll be covering the case of Elisa Lam. You might have heard this case from the Netflix documentary, Crime Scene, The Vanishing of the Cecil Hotel. Elisa Lam was a 21-year-old female. She was Chinese-Canadian who had visited the Cecil Hotel as a tourist, which is in downtown Los Angeles. And she stayed at the Cecil Hotel and disappeared on February 1st, 2013, with her body being found on February 19th in the cisterns of the hotel. And she had been there, we're not quite sure for how long, but obviously quite a sort of distressing scene. Now, what I'm going to be talking about in this particular video is we're going to be focusing on sort of the psychiatric aspects. Elisa Lam had a diagnosis of bipolar disorder. We'll be looking at the autopsy report and we will look at the medication that has been prescribed and just talk about it in a bit more detail because I feel that not enough light has been shed on this particular aspect. Secondly, we'll also analyze the video, the behavior, the strange behavior that's seen in that video, and hypothesize or speculate as to what might be happening, particularly when we connect the medications to the video that we'll see soon. So without further ado, let's jump into the case of Elisa Lam.
With a disturbing development in the search for a young Vancouver woman in Los Angeles. Nearly 3 weeks after Elisa Lam went missing, a body has been found in a water tank on the roof of her hotel. Sinjin Alexander is tracking this. And Sinjin, the obvious question, is it her?
Yeah, I just spoke to the LAPD again, and her body has only just been removed, so it is early. What we do know, it's a woman in her 20s. This is what it looks like at the Cecil Hotel in LA. You can see officials surrounding a water tank. This morning, someone complained about the water pressure at the hotel. When a worker went to investigate, he found the body inside. 21-year-old Elisa Lam went missing on January 31st. She'd been staying at the Cecil. This surveillance video shows the UBC student acting strangely the night she went missing. Once again, the LAPD saying the body has just been recovered.
Now, Elisa Lam was last seen alive January 31st, 2013. She was reported missing February 1st, 2013, and her body being found February 19, 2013. So obviously the Netflix documentary goes through a lot of things, a lot of hypotheses, speculation, etc. But obviously we're going to leave that aside and we're going to focus on two key aspects. She had a diagnosis of bipolar disorder. And it's interesting because she actually had a blog, Ether Fields, as you can see here, where she put down a lot of the thoughts. So this is one of her blog posts. She subsequently went from Blogspot to Tumblr, where that blog is still there. And this particular excerpt from the blog kind of gives us an insight into her sort of mindset. As you can see, some sort of depressive elements are being highlighted here. Now, there are other aspects in the blog that highlight that excitement, which may indicate sort of changes in mood. Having said that, just based on this, we can't necessarily jump into a diagnosis of bipolar disorder or, say, major depressive disorder. There is some discussion that on the blog she's also talked about the discussion of having ECT and discussion with the psychiatrist around having electroconvulsive therapy, which usually indicates a treatment-resistant nature of the illness or a severe sort of depressive symptomatology that's present there. Now, bipolar disorder is essentially a diagnosis whereby an individual has extremes of moods. Now, bipolar 1 means that the individual has mania and depression. Bipolar 2 is usually hypomania, so a milder degree of mania and depression. So if mania is present or hypomania is present, we are dealing with a bipolar disorder. Then we also have bipolar depression, where the individual hasn't had mania or hypomania, but has indicators of a bipolar trait. And this often means that their mesolimbic pathway is activated, such that they have racing thoughts or they have mood swings rather than just unipolar depression, where it's kind of everything slowed down. So racing thoughts, distractibility, irritability, insomnia, early morning wakening, agitation, anger discontrol, etc. These are sort of mixed features. We've done a video on major depressive disorder with mixed features, which comes under the bipolar realm as well. Let's look at the autopsy report. So as we can see here, the date is 21st of February 2013. Note that she was reported missing on February 1st, 2013. And the anatomic findings and pertinent history, I ascribed the death to drowning. So that was a cause of death. And here, other conditions contributing but not related to the immediate cause of death was listed as bipolar disorder. And as you can see here, they highlight 21-year-old Asian woman found in a water storage tank on the roof of her hotel. So you got moderate decomposition, no trauma, and a history of bipolar disorder. Now there is a separate toxicology report, but let's look at the opinion here. The decedent died as a result of drowning, so that's been mentioned. And it showed no evidence of trauma, and toxicology study did not show acute drug or alcohol intoxication. They talk about a history of bipolar disorder for which he was prescribed medication, which we'll look at in a bit more detail. Here it says, quantitation in the blood was not performed due to limited sample availability. Now clearly the body had been there for potentially, a week or more, and that might have contributed to that. So we don't exactly know the contribution of medication within that particular picture. Police investigation did not show any evidence of foul play. But obviously, when we look at the documentary, there's a lot more discussion and speculation. Now let's look at the medication, because this is really interesting. So note that she has a diagnosis of bipolar disorder. We don't know if it's bipolar 1, where mania has been present. A mania is essentially an extreme mood whereby the individual shows elation, euphoria, and it can be associated with psychosis as well. Individuals may have grandiose delusions or extreme hallucinations, such as God talking to them, for example, or feeling on top of the world. They have extreme energy. Decreased need for sleep is a common one. Pressure of speech, they talk really, really fast. Their thoughts might be jumping from one place to the other, known as tangentiality. Hypomania is usually defined as a slightly milder form of mania. So when we think about bipolar 1 and bipolar 2 disorder, the mainstay of treatment is usually a mood stabilizer. Mood stabilizers are come as lamotrigine, we have lithium, we have valproate, topiramate, carbamazepine. These are sort of the main mood stabilizers that are used. With that knowledge in mind, let's analyze this further. By the way, for bipolar 1 and 2, also antipsychotic medications are often combined to treat bipolar disorder. So what we can see here is, of course, dexedrine. Now, what is dexedrine? Dexedrine is dexamphetamine. Now, dexamphetamine is prescribed for ADHD in most cases. A stimulant in bipolar disorder can actually worsen the risk of mania, hypomania, and even psychosis. So that's something that's quite striking here. Can ADHD and bipolar coexist? Yes. There are certain subsets where ADHD and bipolar coexist, in which case one has to provide an adequate buffer of a mood stabilizer, and then a stimulant or an antidepressant, etc., may be prescribed, but this is done under extreme sort of caution and extreme supervision. So it's a really specialist treatment. So one thing there is dexamphetamine. You can see the dose there. This is 10 milligrams. So that's one thing that comes to mind. The second aspect is lamotrigine. Now, lamotrigine is evidence-based in the treatment of bipolar depression. As you can see here, this is 100 milligrams, which is usually an appropriate dose. Sometimes it can be prescribed higher. Now, lamotrigine is evidence-based, better at preventing the depressive pole of bipolar disorder. So in some cases, when individuals have bipolar 1 or 2, which is the manic and hypomanic component along with depression, then a mood stabilizer that prevents the manic pole, such as lithium and valproate, is combined with lamotrigine, because lamotrigine prevents the depressive relapse. So this comes from the Lam-Lit study, lamotrigine and lithium combination, to prevent sort of the up and the down. So lamotrigine is evidence-based in bipolar depression, and it predominantly acts by reducing glutamate hyperactivity excitotoxicity. It's an anti-epileptic agent. Then we have quetiapine. Now, quetiapine is a antipsychotic medication. Essentially, it's a dopamine antagonist. It's a D2,5-HT2A antagonist, which means that it reduces dopamine in the mesolimbic system where psychosis, mania, hypomania occurs. And with the 5-HT2A antagonism, it promotes dopamine in the other areas, so the side effects are minimized. But quetiapine has a prominent antihistaminergic effect, which means that it promotes sedation, prescribed in bipolar disorder, because sleep can be a major issue. Now here, it's a small dose, 50 milligrams, so predominantly antihistaminergic. Not quite sure how much buffer it's providing for mania, hypomania, or for psychosis in that case. Next, we can see Sinutab. Actually, before I go there, what's interesting here is lamotrigine has a doctor prescribed. We can see from where. Quetiapine as a doctor prescribed, but interestingly, loose pills of dexamphetamine. So the question here is, was this obtained from somewhere or was this prescribed? Because using dexamphetamine in someone with bipolar disorder can really trigger off a manic episode or psychosis. So that's really something that's striking, the absence of a prescriber. We know that stimulants such as dexamphetamine, methylphenidate are regulated. Not anyone can just prescribe it. Not any doctor can just write a script and prescribe it. The next aspect here is Sinutab. Now, Sinutab contains pseudoephedrine. As you can see here, these are the ingredients of Sinutab. And pseudoephedrine is known to be associated with psychosis, even in a single dose. So there's a case study, as you can see. So interestingly, pseudoephedrine plus dexamphetamine, the combination of this, if we look at the packaging, it says that sympathomimetic agents, which is what dexamphetamine is, it potentiates sympathetic activity, should not be combined with pseudoephedrine because it can result in a hypertensive crisis, but along the same lines can also potentiate so much sympathomimetic activity, can worsen psychosis. Some of the side effects of pseudoephedrine include psychosis, anxiety, irritability, agitation, sleeplessness, etc. So one of the concerns here is Sinutab plus dexedrine combination in someone with a history of bipolar disorder. Now, the family has reported that previously, in the context of stopping medication, Elisa Lam had experienced hallucinations previously. So there is an evidence of underlying predisposition to psychosis as part of the illness. So the question here is this bipolar disorder with psychosis that she's experienced in the past? Is it schizoaffective disorder that's present? What was the underlying diagnosis is an interesting one. And in someone with that vulnerability, adding on sympathomimetic agents such as dexamphetamine plus Sinutab, which contains pseudoephedrine, can be of great concern. The next one is venlafaxine. Now, venlafaxine is an antidepressant. It's an SNRI. The dose here is 150 milligrams. And SNRI means it increases levels of serotonin, increases levels of noradrenaline, and a little bit of dopamine. So again, activating. Evidence suggests that antidepressants should be used cautiously in individuals with bipolar disorder because of the risk of switch, mania, hypomania that can occur. Similarly here, another dose of venlafaxine, 75 milligrams plus 150. So the total dose is about 225 milligrams. And finally, Wellbutrin. Now, Wellbutrin is bupropion. Bupropion is a NDRI, noradrenergic dopamine reuptake inhibitor. This significantly increases noradrenaline and dopamine, and we know bupropion is used to counteract fatigue. It's a good antidepressant. Here, one of the things we got to take into account, the dose is about 300 milligrams, but the important thing here is bupropion, you got noradrenergic system increased, dopaminergic system. You got venlafaxine, which promotes noradrenergic aspects as well. You've got dexamphetamine, which promotes very significant amounts of dopamine release. We've done a video on this. And we've got Sinutab on top of that. So we've got a combination of medication that can result in significant dopamine and noradrenergic release. That, in someone with a vulnerability towards psychosis or mania, can result in a significant switch. That's one thing that really comes to mind. And in terms of the bipolarity, there's only lamotrigine and a little bit of quetiapine to counteract that aspect. So these are some of my thoughts around medication in this particular case. All right, so now that we've looked at the background history, the autopsy report, past history of bipolar disorder, and the medication, let's look at the video. I'll share some thoughts on that. So let's take a look. There's no real specific aspects here that point necessarily to illness as such or anything abnormal. This is where potentially some strange behavior starts coming in. Here one might classify that as someone being a bit suspicious or scared. Now, if someone was there, it could just be considered playful. But if we sort of look around just at what we've seen, one says there's no one around, then it starts bringing in the possibility of paranoia, the presence of paranoia, they're being followed, sort of persecutory ideation being present, because that suspiciousness can indicate possibility of psychosis, which can occur in bipolar disorder. It can be part of a schizophreniform psychosis, but can also occur in medical conditions. So psychosis is a phenomenon, consists of delusions, hallucinations, and disorganized behavior and speech. So this is kind of where now it does come across as bizarre. We know that in schizophreniform psychosis, sometimes, particularly in the most extreme forms, there's disorganized behavior. There can be catatonic behavior. Now, catatonic behavior can be positivism or negativism. There can be a range of other things. And there's things called posturing. I've had patients where individuals have stood in one place for hours at a time, or, for example, making the same movement, perseverative movements repeatedly. There's things known as echopraxia, copying movements, echolalia, copying sentences. So really bizarre aspects can occur as part of a catatonic type behavior. This isn't necessarily indicative of catatonia, but the posturing aspects, those steps that were just there, if we just go back a little bit, kind of just indicates that little bit of abnormality here. So you can see there, does she think someone's there? She's trying to scare someone. And then if we look at now certain aspects, there's a little bit more that comes out. So this is kind of where, of course, as she comes in, there seems to be an element of fear maybe. And now you can see pressing buttons sort of randomly. So the question here also arises is that, was there an element of confusion, disorientation, time, place, person? We don't know. This confusion is often indicative of delirium. So one's always got to rule that out in bizarre behavior. In fact, should be at top of the list. We know whenever we're looking at psychiatric evaluation, organic or medical conditions should be ruled out first. So you can see sort of this pressing randomly. This is probably sort of the area where it's most abnormal. And the hand movements are almost like posturing. So in catatonia, we tend to see these abnormal or bizarre movements. Other types of abnormal movements that occur as part of catatonia, known as waxy flexibility, whereby individuals' arms and limbs can be put into contorted postures and they maintain it for very, very long times. But there's also things like mannerisms, which are odd, purposeful movements, and stereotypies, odd, purposeless movements. But these are sort of the odd movements that can occur as part of catatonia. There's mitgehen and mitmachen. These are forms of automatic obedience. Strange aspects such as psychological pillow, as you can see here, or waxy flexibility in this particular image. So these are all elements of kind of these catatonic strange behaviors that can occur. This kind of is indicative of posturing if I thought about disorganized psychosis present or catatonic behaviors present here. So again, these are strange movements, which really comes under the realm of psychosis, but as I said, it doesn't tell us the cause of psychosis. Psychosis, just to sort of recap, it is a phenomenon, and there could be several causes. Medical causes could lead to psychosis. Medications can lead to psychosis. Bipolar disorder can be associated with psychosis. Schizophreniform psychosis, schizophrenia, right? So these are all elements that can lead to the phenomenon of psychosis, which consists of delusions, hallucinations, disorganized speech, disorganized behavior, catatonic behavior, and in schizophrenia you also get something known as negative symptoms. Based on that sort of video, now if we combine what we saw in the autopsy report with the medication, and we look at this particular video, it kind of might provide us with some insights as to what might be going on. So let's go through what might be happening here. So what might be going on here? Firstly, whenever we're looking at evaluation from a psychiatric perspective, the first thing that comes to mind is ruling out organic causes and medical causes. So what potentially could be the medical causes that could lead to something like this? We of course haven't gone through an examination, so we don't really know whether there was an element of delirium, which is an acute confusional state, and it usually presents suddenly, acutely, and is associated with the alteration of consciousness, cognition, with a reduced ability to focus, sustain, or shift attention. And it can be associated with there are hypoactive deliriums, hyperactive deliriums, so you can present with agitation or psychomotor retardation. It fluctuates over the day as well. It can be associated with paranoid delusions or persecutory delusions. So this is a possibility in the context of what we saw in that video. Maybe this occurred over a very, very short period of time. Delirium is a possibility, but the question is what might be the causes of delirium. Now, delirium often is due to medical causes. It can be due to infections, it can be due to a head injury, it can be due to, say, for example, post-ictal deliriums after a seizure, metabolic disturbances. Those aspects can lead to delirium, but then substances can also result in delirium, particularly if there's intoxication or there's withdrawal of certain things. For example, in alcohol dependence syndromes, we have things known as Wernicke-Korsakoff syndrome. Wernicke's can be associated with confusional state along with ataxia and nystagmus, so ophthalmoplegia, visual disturbances. So clearly when we see something like this, we must go through a thorough physical examination, bloods, and based on the neurological examination, etc., an MRI or scanning may be required. See, one of the things that comes to mind is, firstly, we talked about that Sinutab dexamphetamine combination. Question is, could the combination of these two have led to a confusional state? Or could it have worsened the psychosis or mania, in which case it becomes a substance-induced psychosis or relapse of the disorder? We know that pseudoephedrine can result in a range of side effects: anxiety, euphoric mood, excitability, hallucinations, irritability, paranoid delusions, restlessness, and sleep disorders. And if sleep disorders occur, we know that can trigger off a manic episode as well. So that's one of the things that comes to mind, is that this combination of medication of bupropion, venlafaxine, which had been prescribed, which seems to have been taken for a period of time, but the dexedrine and the Sinutab are, as we saw in the autopsy report, they don't necessarily have the prescribers present there. The addition of those two is concerning, and we don't know if an overdose had occurred either. So that's one. The second thing is withdrawal. Now, there has been evidence that, she had stopped taking medication in the past and had presented with hallucinations as a result of that. Now, one of the really important things when looking at psychotropic medication, in her case, she's on SNRI, venlafaxine, she is on NDRI, bupropion, dexamphetamine, lamotrigine is there, quetiapine is there. And what we do know is that SSRIs and SNRIs are associated with withdrawal syndromes. And these withdrawal syndromes can present with a range of symptoms, which can include confusion, irritability, anxiety. In vulnerable individuals, can result in paranoid symptoms as well, can result at times with movement disorders. As we can see here, this is the range of antipsychotic withdrawal syndromes. We know quetiapine, antihistaminergic withdrawal, anticholinergic withdrawal. We know that it can be dopaminergic withdrawal that can present with catatonic symptoms. So a withdrawal syndrome is a strong possibility here, particularly even if lamotrigine is stopped suddenly. There can be this almost kind of this GABAergic withdrawal that's present, and that can present with catatonic symptoms. So here there might be a combination of a double, triple, quadruple whammy in a way that is potentiating abnormal behaviors and psychosis and or confusion on top of it, maybe because of either medication induced or cessation abruptly. So that's a possibility. The other aspect to take into account is there is the delirious mania. Now, delirious mania is an entity, it's the most extreme form of mania, and such disorganized behaviors can be seen in delirious mania as well. So for example, here are some examples of case reports. She alternated between excitement and mutism. She also displayed episodic absent-mindedness with a staring expression, echolalia, echopraxia, which are repetitive imitative behaviors, disorganized behaviors, and impulsively touching others' faces. So you can see the bizarreness here. That bizarreness was also evident in that video that we saw. Another example, he was inattentive, disoriented to time, place, and person, unable to find his bed. He was awake all night, busy without clear goals, spoke incoherently, and has decreased appetite and intake. He took boxing stances, this posturing, and pumped his thigh at times without reason, showing catatonia-like symptoms. So again, sort of fits in with some of that posturing behavior, abnormal movements that we've seen. So delirious mania, by the way, should also be considered as a subtype of catatonia. And I talked about catatonia saying catatonia consists often of strange and abnormal postures adopted habitually is one symptom. It's known as posturing. Stereotypies and mannerisms I talked about, which was evident. Echopraxia, echolalia, but there are other aspects which I haven't covered, but these are some of the aspects that you can look at in catatonia, as you can see. Mitgehen, ambitendency, mitmachen, present, positivism, negativism, gegenhalten, all of these different terms that are there as part of catatonia. Finally, this could just be an actual relapse of bipolar disorder with psychosis or a schizoaffective syndrome. So the possibilities could be a medical delirium, substance-induced delirium, substance withdrawal delirium. This could be withdrawal syndrome resulting in catatonia, or this could be a relapse of bipolar disorder with psychosis or a schizoaffective kind of syndrome. Bear in mind that these are speculation based on what we see from a mental state examination, from the medication, which gives us some insight. What I'm trying to do through this is also sort of enhance some of that learning through different ways, rather than just reading a textbook, for example, or listening to a lecture. By connecting it to real life experiences, we can just learn that a little bit better. So I hope that you found this video insightful. Of course, a tragic story, so condolences to the family. So if you're interested, of course, you can watch all the other speculation around it by watching the documentary on Netflix. If you liked it, leave us a like, and don't forget to subscribe to the channel. I look forward to seeing you in another video soon. Take care and stay safe. Bye-bye.